All right, Kiran, I'm really excited to have you on the podcast today. And I was so glad you reached out to discuss this topic because I like to set the stage a little bit and go back to the title of the podcast, the Pelvic Floor Project. And I picture that I am going to be sharing this episode with clients that come in and they may come to see a pelvic health physiotherapist because of symptoms like pain with intercourse or bladder urgency or stress incontinence or something like that. They're coming in for that reason. And then when I ask them different questions on their intake form, I always ask about history of UTIs or, are you using antibiotics frequently for UTIs? Do you have symptoms of it? And I think everybody tends to think of things separately. My UTI is separate from my pelvic floor, or my physio is separate from my doctor. And yes, they seem separate, but my goal of this podcast is to help tie everything together and help people see the big picture. So I'm really thankful that you brought up this topic because this is an important one as it relates to the pelvic floor. So, Kiran, before we get started, will you introduce yourself to the listeners?
Yes. Hi, Melissa. Hi, everyone that's listening. My name's Kiran. I'm a first-year resident doctor in obstetrics and gynecology at McMaster University in Hamilton, Ontario. I am also a member of the Be Pelvic Health Aware team, which is an initiative that was started by Dr. Roxana Jeffrion, who is a urogynecologist in Vancouver, and the rest of her team.
That's great. And will you set the stage a little bit as to why you are interested in discussing this topic? Because, I know that as healthcare providers, we're always interested in disseminating up-to-date information and helping not only the general public, but other practitioners keep up to date. So will you talk a little bit before we get going about the goal of the Be Pelvic Health Aware campaign? Because for some people, they haven't heard about it before.
No, for sure. So Be Pelvic Health Aware is a project that was started and sort of was an idea that was founded by Dr. Jeffrion. Her specialty of urogynecology is looking at pelvic floor disorders. And this is a very specific topic within obstetrics and gynecology. This includes conditions such as pelvic organ prolapse, incontinence, bladder concerns that women may experience and patients may experience. And the purpose of Be Pelvic Health Aware was to create a platform where information for patients can be condensed with non-medical terminology in words that they may be able to better understand their conditions. And so this project essentially is a website as well as social media campaign where we share different information about the various pelvic health issues, as well as share patient perspectives to be able to allow for that connection that patients may feel through hearing those stories.
Mm-hmm. And, as a resident in gynecology, I'm sure you've already been exposed to physiotherapy. I mean, I'm definitely seeing, especially in our community, we've got so many new gynecologists and they refer to physiotherapy quite often. And I think anyone that's listened to this podcast before will start to be able to tease out, there's a lot of evidence to support the role of physiotherapy in the things that you see too. And so I think that our relationship is very symbiotic in that way. And I'm sure this is new because I think even 10 years ago, you wouldn't have been exposed to physiotherapy the way you probably are now in your training.
That's very true, Melissa. I think not just in obstetrics and gynecology, I think in all of healthcare, multidisciplinary healthcare is the sort of up and coming approach to patient care. And that's because as physicians, we might have a certain area of expertise, we might have a certain area of knowledge, but patient care needs to be holistic. It needs to involve various different aspects of their life, emotional, mental, physical, spiritual even. And so I think in gynecology and even obstetrics, the link between the physician and the pelvic health, sort of the pelvic physio team is critical to be able to provide, that long-term longevity in their pelvic floor health. Because as we know, pelvic floor health isn't just a one-time diagnosis, it's an ever-evolving condition for some patients.
That's great. And so if we dive into the specifics on kind of the topic of urinary tract infections, can you first start off by what exactly is a UTI and some of the common symptoms?
Yes, for sure. So, urinary tract infection, or UTI for short, it's actually one of the most common bacterial infections experienced by women. And to the point that at least 50 to 60% of women will have at least one UTI in their lifetime. And that is a large amount if we think about it. And a UTI is specifically an infection of the urinary tract. So the urinary tract includes our kidneys. It includes the ureters, which are tubes on both sides of the body that come from the kidneys and connect to the bladder. It can be an infection of the bladder itself, or it can be an infection of the urethra. So that's the tube that connects the bladder to the outside world where we're able to urinate through. And in terms of the diagnosis of UTI, if you have symptoms and are diagnosed with UTI through cultures 3 or more times in 1 year, you might hear the term recurrent UTI from your healthcare provider. In terms of the symptoms that we look for on our end when we're taking your history, and even yourself, Melissa, when you're taking the history, includes frequent and painful peeing. And sometimes patients describe it as a burning sensation. And the frequency that describes the need to run to the bathroom. And there's this sense of urgency. The other aspect is lower abdominal pain. We might describe it as suprapubic pain, meaning tenderness in the area just above the pubic bone. And for some patients, this might or might not include hematuria, which is red, strawberry red urine, essentially blood in your urine.
So would you say then that, if you have those symptoms, most people would go to their family doctor? And then can you describe how urine cultures are taken? Like, what's the process for them to actually find out if there's an infection?
Right. So for the diagnosis of a UTI. So essentially what happens is that you would visit your family physician, your healthcare provider, and they would first take a history to ask you the questions to see if you're experiencing these symptoms, if you've ever had these symptoms before, if there's any other risk factors that we'll get into as well. After that, they might ask you to pee in a cup, in a clear cup. And usually what happens is they'll do a dipstick test, a urinalysis, which is it's a quicker way of analyzing the urine. And the urinalysis doesn't help us rule out an infection, but based on what we see on the urinalysis, it can pick up blood, it can pick up certain components that are released by bacteria called nitrites. And if those are positive, then that's a high likelihood and in conjunction with the symptoms that the patient is experiencing, that there is probably a urinary tract infection. But the gold standard to diagnose a urinary tract infection is that urine culture. So that can take a few days to come back, and that helps us get an idea of what bugs might be growing in the urine. And the method that you would hear your provider ask you when they give you that cup, or even the assistants in the clinic, would be a midstream urine, meaning that's a clean catch, because we don't want the sample that is collected to be contaminated by any other bugs in the area.
So would you say that you wouldn't go to the gold standard, the culture initially? You would treat the symptoms based on kind of the dipstick first. If that's not treated successfully, then you might move on to the culture. I mean, I know that's not always happening that way, but would you say that most often is the course?
So what happens is that when we do take the urinalysis, the sample, only a component of that is only the dipstick only touches the urine. So you still have the whole sample, and most providers will actually send it off for culture. Is because the importance of the culture is that it will tell us exactly what bug is growing. And also it'll provide what's called susceptibilities, meaning that it will tell us if the bug is, or which antibiotics the bug would be susceptible to, which antibiotics would be effective in getting rid of that bacteria. And then also, more importantly, it will tell us which antibiotics the bug is already resistant to, meaning that those antibiotics won't work in getting rid of that bacteria.
Okay. Who would you say is more prone to UTIs?
Right. So in general, patients, that have diabetes or patients that have a weakened immune system for any reason, they have a history of developing bladder stones, or for any reason they need to wear a tube or a catheter to drain their urine or their bladder. That is a higher risk factor for UTI. If patients are pregnant or if patients are postmenopausal, they're also at a higher risk of UTI. In addition to that, patients that are frequently sexually active, they use spermicides for contraception, or they have multiple and new sexual partners, that also increases the risk of developing a UTI.
Will you talk a little bit more about why I can picture that most of the people that I would see or that I would be recommending this episode to would be the postpartum women or the perimenopausal women. Can you talk a little bit about why that is? What is happening at that time that's making them more prone?
Right. So in that postmenopausal phase, what is happening is that there is a lack of estrogen in the local vaginal tissues. And in particular, in the vagina, there's a bacteria that's called lactobacillus. That bacteria loves estrogen, and that is what allows our vagina to be colonized by lactobacillus. The relationship there between lactobacillus, estrogen, and the urinary tract infections is that E. coli is one of the most common bacteria that causes UTI in women. And lactobacillus is effective in preventing E. coli from colonizing their urethra and then ascending in its infection. In the postmenopausal phase, when there isn't enough estrogen on board, there's not enough lactobacillus in the vagina to be able to prevent E. coli from infecting and spreading in the urinary tract area. And that's why in the postmenopausal phase, one of the recommended treatments for vaginal dryness, vaginal irritation, as well as patients who might experience recurrent UTI in the postmenopausal phase, the recommended treatment will be vaginal estrogen in addition to any antibiotics.
And I'm sure you're seeing we're going through a massive transition here of, you know, educating people about estrogen, because I did a whole episode with a urologist on kind of the fears around estrogen and the up-to-date evidence. So I'll make sure I link that in the show notes. But I'm sure that's a lot of what you're doing right now is just providing education about estrogen, because I actually have someone in mind right now that, initially when I asked her, she was coming in with symptoms of frequent UTIs. She was describing always on antibiotics and not seeming to touch the problem, starting to have more bladder urgency, leaking, pain. And when I asked about estrogen, because she's right in that age group, oh no, I would never take estrogen. And so I find sometimes these episodes are so helpful. As a physiotherapist, I can't recommend, nor can I necessarily counsel on estrogen, but I can say, listen to this. I just want you to go home and listen to this. And then I wonder if you should have a conversation with your doctor, because it sounds like you've tried some of these other things. But I imagine this is something you spend a lot of your time with, educating about the benefits or the need for estrogen quite often.
Yeah, and I think as you touch on that, Melissa, I think the importance here is patient education, being able to communicate in language that is non-medicalized, so that the patients can really understand that we understand what they're saying and what their concerns are, and we're validating those concerns. But at the same time, we provide the patients with resources such as the podcast, such as Be Pelvic Health Aware, where we're outlining research-supported, evidence-supported treatments and options for patients. And sometimes, with patients, it might be that you have a conversation and you come up with a plan that, okay, you might be hesitant to try X treatment. Let's go down this route for this number of weeks. If it helps, great. If it doesn't, then we'll come back to this conversation. I think that sort of dual conversation between providers and patients is extremely important. We're partners in their healthcare. They are as entitled to their healthcare, as we all are to our own healthcare. So being able to invite patients into the conversation and allowing for that patient autonomy, I think, is crucial to be able to provide effective treatments for patients.
So would you say then if someone comes in to see you around that, postmenopausal, menopausal age and they have symptoms of a UTI, you're first going to kind of test their urine to find out, if anything's growing and what they're resistant to. But would you say then that practice suggest that you would start them on estrogen at the same time if it looks like in your vulvar exam that they would benefit from estrogen? Would you say it's usually I'm going to start this first, and if once your UTI is cleared, we're going to start you on estrogen, or would you tend to send them home trying both? I know it's a very individual process, but I'm curious to know if someone what would they expect going to an appointment?
So going to an appointment in the postmenopausal phase, for example, is what we're chatting about. If there are symptoms of urinary tract infection, the first thing would be to take a urine sample from the patient. You would analyze it, send it off for culture. But at the same time, you would dive further into the patient's sort of other symptoms. So you would ask about, you know, symptoms such as painful intercourse. Do they feel that their vaginal area is irritated? Is there vaginal itching? Are they bleeding from the vaginal tissues because of how fragile they can become with the lack of estrogen? So that appointment wouldn't just be to ask the patients about their urinary tract symptoms and treat that. We want to be able to treat the rest of the pelvis as well. During the you would invite or ask the patient if they would be open to doing a pelvic exam. You would assess the tissues to see, the health of the vaginal tissues, estrogenized tissues. Usually we are looking for sort of a pink color to the tissues, which indicates there's enough estrogen on board. The other aspect that the pelvic exam would also evaluate in postmenopausal or any patient that we're doing a pelvic exam on is looking for prolapse. So any bulging of the different components of the pelvic organs into the vagina, because that is also a risk factor for developing urinary tract infections. We also ask patients about symptoms of incontinence, so leakage of urine with activity or with urgency. And so that becomes the whole sort of pelvic floor assessment through examination and questions of symptoms. And then you treat those symptoms. So for the urinary tract infection, if we are thinking that those symptoms, so especially if the patients have frequency, they have painful urination and they have hematuria, but they don't have any vaginal, abnormal vaginal discharge, then the likelihood that their culture will return positive is actually above 80%. So in those cases, some providers may decide to start on empiric antibiotic therapy. And then when the cultures come back, they will ensure that the antibiotics they provided work on getting rid of that bacteria. And if they don't, if the cultures show that that antibiotic is resistant, then they will switch you to a different antibiotic. But at the same time, if there's concerns about the vaginal tissue, then they will invite a conversation about starting you on estrogen.
I love it. I love that it's because I do see people kind of thinking of it as a siloed approach. You need estrogen for this, you need antibiotics for this. But very much it can be, okay, what's going on here? It's not always the same, right? What happens then? So let's say they have symptoms of a UTI or some of them, but the culture comes back negative or the urine tests come back negative. What kinds of things would you be thinking then?
So that's a great question, because as we were touching on before, that urine culture is the gold standard for diagnosing UTI. But in the case that the urine culture comes back negative, so the first thing would be to ensure that the culture we got was that midstream clean catch, to ensure that there's no contamination. So on the report for the culture, we can sometimes, they do report if it's a contaminated culture with something like skin cells, for example. But then in the other side, we want to think about the other aspects that might be causing those symptoms. Maybe this patient doesn't have a urinary tract infection. Maybe there's something else going on. So there are other conditions that can mimic urinary tract infection symptoms. Weak pelvic floor muscles and prolapse and incontinence can cause urinary tract infections, can lead to urinary tract infections, but also they have similar symptoms. So that physical exam becomes really important in determining if a patient is experiencing prolapse or incontinence, and also the history. The other aspect is inflammation of the vagina, so vaginitis, inflammation of the urethra that is not related to a UTI, inflammation of the bladder wall called interstitial cystitis. All of these can mimic UTI. In addition to that, infection or inflammation of the other pelvic organs, so the uterus, fallopian tubes, ovary, called pelvic inflammatory disease, can also mimic UTI. And then bacteria or infections that cause sexually transmitted infections, such as chlamydia, gonorrhea, and then other bacteria such as Candida, bacteria vaginosis, as well as even herpes, they can all mimic UTIs. So if a culture comes back negative, what would happen is the healthcare provider would follow up with the patient, because the other thing is we don't want them to be on antibiotics. If you've started empiric antibiotics, you don't want them to be on antibiotics if you're not treating a UTI. So then you would invite the patient back for another visit and then dive further into the other possibilities, other differential diagnoses, and ask questions related to those to rule in or rule out those causes.
I'm curious to know then, well, actually, because you've kind of touched on all this, but I just want to lay it out a little bit more clearly. So if someone presents with symptoms of a UTI, the practice guidelines, I guess I want to tease out, where does pelvic floor physio fit in? So the practice guidelines you've already laid out: test the urine, see if a discussion around estrogen is warranted, rule out some of the differential diagnoses. Where does, if anywhere, where does pelvic health physiotherapy fit in the practice guidelines, if they are there?
Right. So I think in the practice guidelines, they touch on the fact that weak pelvic floor muscles or pelvic floor prolapse and incontinence are risk factors, especially in the postmenopausal phase of recurrent UTIs and urinary tract infections. So if, based on your assessment, the patients are having symptoms of pelvic floor concerns, as well as they're having a history of urinary tract infection-like symptoms, then again, that's, that holistic approach. So recommending pelvic floor physio wouldn't be harmful. In fact, being able to strengthen your pelvic floor would be one way that you could potentially prevent your chance of having a further UTI after treatment, of course, if that is the diagnosis. And that is because with prolapse as well as incontinence, there's a risk that you're not emptying your bladder as effectively as you otherwise would. And then that becomes a scenario where bacteria such as E. coli love, and they could lead to infection and urinary tract infections.
And if I could add, like, as someone that does assess people that come in with some of the symptoms that you've mentioned of prolapse or incontinence, frequency, quite often I'll say to them, what is your interpretation of what's going on, or what do you believe this is related to? And almost everybody says, I think I have a weak pelvic floor. And before I even assess them, I explain that the pelvic floor is such a responder, such a first responder. Quite often it's not inherently weak or loosey-goosey, but more upregulated, which leads to fatigue, which will feel weak. So it might feel weak, but quite often when you assess them, they are holding on to so much tension that there's a fatigue factor. And the tension or the upregulation can lead to pain, frequency, difficulty emptying because their tone is high or their resting tone is high. So when they sit on the toilet, they have a hard time letting those muscles fully relax and empty. And again, it will feel like weakness because no muscle in our body wants to hold extra tension all the time. But I think that is it is something that people picture, simple sagginess of their pelvic floor, when quite often it is an overactive tension with fatigue. So it is definitely one of those misconceptions out there. People believe it's all simply weakness, and sometimes they're at home doing Kegel, 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 when really it might actually be counteracting what they need, what they might benefit more from some down training. I'm curious to see, I'm kind of putting you on the spot a little bit here, but do you notice sometimes too, some of these people that you see that have symptoms of UTI and they don't have signs of infection. Do you sometimes find that they're people with a lot of stress, or they're in a stressful time of their life, or maybe they seem to be anxious people? Would you say that you notice that, Kiran?
Um, that's a good question. I wouldn't say that that's something that
That
I've
you all,
generally tuned into. Um, uh, we know that any sort of infection is distressing for patients. So I think it's not necessarily something that I've connected the dots on, and I wonder if there's any literature on it. Yeah, I don't know. It's something I've noticed. Maybe now I might move forward,
and
pick up on, but
yeah, definitely not always the case, but sometimes I find the people that are like, I have tried everything. I mean, I keep going through all the motions and the symptoms keep showing up and they keep telling me there's no infection. And that's definitely something that I would think about is let's start working on relaxing your nervous system, relaxing your muscles, and let's see what happens. Yeah, I'm curious to see if you kind of just think about that in the back of your head. The people that are not showing up with positive results.
The other thing also is I wonder, when we see patients in the clinic too, is, if patients know that they're going to, for example, have a pelvic exam, that's an invasive examination, right? It is hard for patients. So coming into those appointments, they also might be a little bit more anxious. And as obstetrics gynecology, in the field of obstetrics and gynecology, that's something that we are aware of in the back of our minds for all of our patients. So, setting that stage, having that conversation, being clear in our communication are all things that we do to be able to allow that, that interaction we're having with the patient, allow them to feel at ease when they're having that conversation with us, and when there might or might not be a pelvic exam that might be needed.
Yeah, of course. Will you talk a little bit about the consequences of a UTI being untreated? Because I think there's always, there's some people that, you know, really don't want to take antibiotics, or for whatever reason they're putting it off or something like that. Can you talk a little bit about the consequences of that, or what might happen?
Yeah. So, one of the consequences that we worry about with an untreated UTI is that it can what's called ascend. So it can, essentially go up the urinary tract that we talked about at the beginning of the episode. It can essentially, from the urethra, that's where it's starting, lead up to the bacteria. It can cause significant inflammation of the bacteria, of the bladder, and lead to more symptoms. It can go further up the tubes on both sides of your body to the kidneys. In that case, we worry about what's called pyelonephritis. So that is severe infection of your kidneys from a bacteria going up your urinary tract. And that can lead to more what we call systemic symptoms. So patients might feel extreme fever, chills, they might have really severe back pain. And from there, we worry about as well that if it's untreated and goes untreated for a long time, that we worry about the bacteria getting into the blood and causing a more severe infection. That the patients might need a more involved treatment for, and sometimes even hospitalization.
Mm-hmm.
And so, even though, I guess what the point is, that even though urinary tract infections are very common, they can lead to significant patient morbidity, and being able to treat them early and effectively are two crucial points in patient treatment and patient care.
And what about the marketing around? Because I mean, marketing is huge for things like douching, special soaps, steaming. You'll hear all sorts of things. Can you speak a little bit to that? Because people are hearing that this is something they should do to keep their vagina or their sensitive tissues clean.
Yes. So we know that these advertisements exist in the world on TV, on social media, and they can be quite convincing. in making people believe that those are treatments that they should invest in. But we know from research, as well as from speaking with patients, that these strategies of douching and using special soaps will not necessarily get rid of the bacteria that leads to urinary tract infection. And most commonly, it's E. coli. E. coli is found in the stool, and it's at a microscopic level. And in fact, these special soaps or douching strategies can further lead to inflammation and increase the risk that the patient might develop not just a urinary tract infection, but also vaginal infection. So whenever we speak to patients, we always alert them about these other options that might be out in the community, especially if they bring it up to us as well, that they are not recommended from the guidelines.
Okay. Will you speak a little bit, because I'm thinking right away of another population that you've mentioned already that can be prone after intercourse. Can you just speak to why are we more likely to experience a UTI after intercourse? Some people.
Right. So with intercourse, it can increase the rate that the vaginal area, and then the vagina is very close to the urethral opening. It can increase the rate at which those areas become colonized or become infected with E. coli. So it becomes an easier way for that bacteria to find its way to those areas. And if the patients are prone or have risk factors for UTI, it can make it that much easier for that bacteria, such as E. coli, to further infect that area and lead to symptoms of urinary tract infection. And then on that realm of sexual health, for patients that might use spermicide for contraception, it also becomes a similar idea. Except with spermicide that's used, it can also get rid of that good bacteria that we were talking about, lactobacillus. And so for patients that are using spermicide in sort of the premenopausal years of their life, that becomes a mechanism also for which E. coli and other bacteria can take over when there's a lack of lactobacillus, because the spermicide is getting rid of that good bacteria.
Can you tell me a little bit about, I know that one of the projects, well, actually, correct me if I'm saying this wrong, but one of the projects that you have been working on with the Be Pelvic Health Aware campaign has to do with UTIs after surgery, after surgical procedures. And obviously that, again, is not something as a physiotherapist that I'm necessarily involved with, but a lot of my clients are. And I'm curious if you can talk a little bit about that, because from what I understand, it's a time where people are more prone to a UTI.
Yes. So we chatted about the pelvic floor disorder. So prolapse and incontinence can lead to UTI. We chatted about how pelvic floor physio is sometimes the first line treatment that patients would, after having a discussion, we speak with patients, and that's the direction that they would like to attempt to see if they can resolve some of those symptoms related to the pelvic floor conditions. But for some patients, those conservative managements with pessaries or with pelvic floor physio are still not enough to help with resolving the symptoms related to pelvic organ prolapse or incontinence. And in those patients, then we have a conversation about whether or not surgery is indicated. So pelvic surgery would then become another risk factor for patients developing a post-operative urinary tract infection. And for those patients, the risk comes from the fact that in surgery and the few days after surgery, we would place a tube in their urethra to allow them to pee, because of the sort of close proximity of where we are operating. And also in the post-operative period, while you are regaining sort of control of the bladder, there can also be what we call prolonged voiding dysfunction, meaning that the bladder, you're not urinating effectively, and there's retention of urine in the bladder. And that also increases the risk of developing a UTI in the post-operative period. Based on research, there's a wide range of percentages that we know, and anywhere from 7% to even up to 34% of patients can develop a urinary tract infection in the postoperative period.
Can you talk a little bit too? I mean, we've talked about, well, let's summarize some of the things that people will hear about. We've talked about estrogen a little bit, and maybe we'll talk about that a little bit more, but can you talk about cranberry? You know, I think in the past, people used to just think you just need to go buy cranberry juice and you just need to drink and drink and drink. And actually, from what I understand, there's some very supportive evidence around a type of cranberry. But will you talk about that? Because I know this is something being prescribed quite often.
Yes. So that's a great point that you bring up about cranberries and essentially in what component the patient should be taking them in to be able to be effective. So there was a randomized control trial that was done by Foxman et al. So that team that looked at the effectiveness of cranberries being able to prevent post-operative UTI in patients that have gone through pelvic surgery. And so for the patients that took cranberry extract pills, so not cranberry juice, because through cranberry juice, you would not get the required dosage of the component of cranberry that is effective in preventing UTI. Cranberry extract capsules that were prescribed to patients, it decreased the urinary tract infection rate by 50% compared to patients who didn't take cranberry extract pills in the postoperative period. That's a big decrease. And the difference there is that there's the cranberry extract or the cranberry extract capsules contain a component called proanthocyanidins or PACs. And those components of cranberry are shown to be able to prevent the sort of the hair-like projections of E. coli from attaching to the bladder wall. And that's how cranberries prevent UTIs. That's the mechanism through which they work. And the recommended dose is 36 grams of cranberries per day to prevent urinary tract infections. And that dose you wouldn't get from drinking the cranberry juice. It would come from over-the-counter cranberry extract pills.
Okay. So would you say then, because you mentioned that randomized control trial was done for post-surgical patients, do you extrapolate that? And quite often, are people prescribed that, or are people recommended that that maybe for different reasons be susceptible? Or is it, sorry, is that information from the RCT being extrapolated? Like anybody that's prone to UTIs, would they be recommended the cranberry extract? Or is it just post-surgical procedure or recommendation?
So it is a recommendation in the guideline for patients that are prone to recurrent UTIs as well as in the postoperative period. So based on risk factors or based on the fact that, if a patient has or is getting close to 3 or more urinary tract infections proven by culture in 12 months, then you talk about these other options of preventing further UTIs. And in that case, or even before a patient, if a patient is diagnosed with their first UTI and you think that they might have risk factors for developing recurrent UTI, then the advice might be to start on supplements, cranberry extract supplements.
And can you talk about, are they similar, or is there a difference between the cranberry extract and D-mannose? What's the difference there?
D-man. Oh, actually, sorry, I'm just pausing.
Okay.
D-mannose. I don't think that's anywhere in the guidelines anymore.
I wonder if it's just I wonder if it's something that's used in the States or something, but I keep hearing, I almost hear them, it seems to be used interchangeably. Like some people will say take D-mannose. And when I look at it, I feel like I looked it up very a preliminary search. I'm like, this sounds like the cranberry extract.
D-mannose is not is not in the Canadian guideline for sure. Oh, and it's glucose, so it's not similar to cranberry extracts actually, because it wouldn't have that component of PACs. And so I don't know enough about D-mannose, to be honest, Melissa.
That's okay. I'll just not ask that. Let's just take like 10 seconds to pause here. And then I'll tell my husband, like, you're going to have to listen back and cut out where it's appropriate. And then in that 10 seconds, I'm just going to think about what I'm going to ask next. I'll pause until I'm ready to ask you something. Okay. So Kiran, let's say that I just want to kind of sum some of this up for some people listening that have had a really hard time troubleshooting this with their care provider. So I think what you're saying is if you have symptoms of a UTI, don't ignore it. Go to your provider. Um, if they should be doing a urine test and probably a culture. They might send you home treating it. Would you expect, or I always want to help people educate and be an advocate for their own health. Would you also suggest that if their care provider does not offer to do a vulvovaginal exam, that they ask for that? Because I hear this a lot, that my clients say, well, nobody looked. They just gave me an antibiotic. So I think what you're saying though is that they also need to be, there's an exam required to see, like, is this person really needing some estrogen or is something else going on? Like, to truly know the big picture, should they not be advocating for an exam?
That's a great question. And as we were chatting about earlier, sometimes even based on history, we can sort of get an idea that, okay, this patient might have a urinary tract infection, in particular if they have the symptoms of frequent painful peeing, if they have, any hematuria, which is the red urine, that points us towards the direction that, okay, this patient might have a urinary tract infection, especially if there's no other vaginal symptoms. And also that urinalysis can be done right after a patient pees, that dipstick, and that'll also give an idea. But in terms of the physical examination, for providers, we also might want to feel a patient's belly. We might want to see, if there's pain above that suprapubic area. We might want to, based on history, might want to feel their back to see if there's, what we look for is sort of tenderness in the flank region, to see if the kidneys are involved or not. And that'll also come from the history. So a targeted physical exam to ensure that we're not exposing the patient to any unnecessary examinations is extremely important. In terms of the pelvic examination, if the patient feels that they have other pelvic symptoms that they're concerned about as well, then sometimes, like as we talked about, the lack of estrogen in the vaginal tissues, if the patients are worried about vaginal itching, if they're having vaginal dryness, if they're having pain with intercourse or any symptoms of prolapse or incontinence, then yes, a physical examination would be warranted as well. And that is something that the patients can advocate for.
And do you have concerns about antibiotics being prescribed too quickly? Like, I understand that, if the urinalysis shows something, you need to treat it. But what do you see in your experience? Sometimes they are being prescribed. I've heard before people say, my results are coming back negative, but they don't really know what else to do. So I just keep using these antibiotics. Those people, my hunch that you'll say, just maybe probe further, or ask your care provider, well, what else can we do? What else can we do? Maybe they can self-refer, they can come see the physiotherapist to rule that out. Can you speak a little bit to that? Because that comes up, and I guess I'm hoping for your guidance on what to suggest there.
So I think there, Melissa, you're touching on the important topic of antimicrobial stewardship. So we know that in general, antibiotics for various different reasons may be overprescribed and may be overused. And in that case, we're seeing the development of very resistant bacteria in so many parts of the body. And so the importance of prescribing antibiotics when you are certain that there is an infection is extremely important. And that's where the appropriate history taking, as well as plus or minus a physical examination, is extremely important, as well as the urinalysis and urine culture, just to reiterate. But for patients that are having recurrent sort of urine cultures that are coming negative, it's important to investigate some of the other causes that we talked about earlier in the episode. But also, if patients are having, what's called persistent, if they're having persistent red urine, and or the culture is actually growing something that is not E. coli, then what might be the next step for patients is what's called a cystoscopy. So it's where a camera is put into the urethra and it actually evaluates the bladder and the integrity of the bladder wall to really see if what else is going on, what else might be causing these symptoms, so that patients aren't put on unnecessary antibiotic course, which might lead to further problems down the line with resistant bacteria.
Perfect. Kiran, this has been super helpful. And I wonder, is there anything that you feel I haven't asked you that you want to make sure that we get across in this episode?
I think we had a great discussion, but I think I just want to reiterate for everyone that's listening that urinary tract infections are incredibly common. 1 in 2 women will have a urinary tract infection in their life. And so being able to recognize the symptoms from the point of view of healthcare providers, being able to treat with appropriate antibiotic, whether it's empirically or whether it's after culture proven UTI, really listening to the patient's symptoms and validating those symptoms is extremely important. And then for the patients, if you're worried, if you're thinking that you might have a UTI, not to ignore those symptoms, to make an appointment with your healthcare provider and have a full assessment to be able to be treated appropriately.
Will you tell everybody really quickly, and I'll make sure that I add it into the show notes, because I know that you guys through the Be Pelvic Health Aware campaign have put together several different visuals to help clients understand not only this topic, but I think there was one on stress incontinence, one on prolapse, different perineal tears. I know I've talked to Dr. Jeffrey on about before, but can you just tell them where they can find this information, not only for practitioners to remind themselves about some of this information and how to disseminate to their clients, but where can clients find more information?
Yes, absolutely. So the website is www.bepelvichealthaware.ca. We also have a Facebook page by the same name, Be Pelvic Health Aware, as well as an Instagram at Be Pelvic Health Aware. You can follow us on those platforms. We post information constantly throughout the month about various pelvic floor health conditions, tips, advice, as well as on the website, we have the videos that you're alluding to there, Melissa. Those are on topics of perineal tears. Those are on topics of urinary tract infection is our latest video. We also have a tab there where we are summarizing some of the research that is coming out of the group and the team that we're working on. We summarize it in a paragraph for patients, and it's the published literature that we're summarizing on there related to pelvic floor conditions. And then for healthcare providers, we have a tab called Spread the Word. And on there, we have added some toolkit as well as some patient sort of brochures and pamphlets based on our videos that providers are free to use in their clinics and share with their patients as a resource.
Well, listen, I feel very happy and refreshed to hear that you and other people that are around the same stage in your training are learning more about what we do as physios and about this interdisciplinary learning and education and support for our clients, because that is so important. So I'm so thankful to hear that we're starting to work together more. And I also am honored that you asked to be able to spread some of this important information on this platform, because it's exciting to be able to work together and learn together and support our clients better. So thank you so much.
No, thank you, Melissa. I think the Pelvic Floor Project podcast is such an excellent resource. And as you said, I think teamwork is the dream work when it comes to patient care. So thank you for this opportunity, for having Dr. Jeffrey on the podcast before and now me. It's our honor, honestly, to be able to speak to you as well as the listeners through this podcast. Thank you for the opportunity.